Thank you for the opportunity to present my second lecture, Imaging of Neoadjuvant Therapy in Breast Cancer Treatment. Again, my name is Jessica Leung, and I am breast imaging radiologist at MD Anderson Cancer Center in Houston. What are the indications of neoadjuvant therapy? They include the locally advanced cancer, inflammatory breast cancer, and the large inoperable cancer. Now, in addition to these large locally advanced inflammatory cancers, neoadjuvant therapy is increasingly administered to high-risk disease, which may be small in size. This is high-risk disease that would otherwise require adjuvant chemotherapy. High risk as based on clinical and radiologic findings, and as based on tumor biology. For example, your triple negative and your HER2 positive cancer. Let's start by looking at some MR images of a patient before and after neoadjuvant therapy. You see on the top here in the subtracted image, you have non-mass enhancement, which represents diffuse cancer in this breast. This is the associated color parametric map. After neoadjuvant therapy, you see that nearly all of the abnormality, the abnormal enhancement has resolved. So this is a good response. These are axial images of the breast itself, and I'll also show you the sagittal image to demonstrate the axilla, which is here, showing you adenopathy, which also shows response in neoadjuvant therapy, as shown here on the bottom right-hand image. One of the major purpose of neoadjuvant therapy is to reduce the tumor burden so that the cancer that was not operable previously can now be operated upon, and perhaps even with breast conservation. Breast conservation therapy is defined as the combination of breast conserving surgery, i.e. lumpectomy, along with radiation therapy. And we know that breast conservation therapy is more likely to succeed if the tumor burden is lower. This figure shows you that the larger the tumor burden preoperatively, and this here on the right-hand side is greater than 5 centimeters, the higher the chance of failure. So larger lesion, less likely breast conservation therapy is to be successful, versus the small cancers here have a lower chance of failure, higher chance of success of breast conservation therapy. So reduction of tumor burden, one of the purposes of neoadjuvant therapy. Another very important purpose is to provide prognostic information. At this point, I would like to introduce you to the concept of PCR, which stands for pathological complete response. What this means is that after neoadjuvant therapy, when the patient undergoes surgery, you examine that piece of tissue histologically, and there's no tumor left. That would be considered a pathological complete response. And this is significant because studies have shown that pathological complete response is a very good surrogate marker. It's a good surrogate marker for the future. Correlates with longer disease-free survival and longer overall survival. I would like to introduce you to a parallel concept, which is RCR, which stands for radiological complete response. And we are going to go over this concept several times during this lecture. Radiological complete response basically means that at imaging, we no longer see any evidence of disease. A big question, which I would like to pose at this time, and we'll consider as the lecture goes on, can RCR be used to predict PCR so that surgical excision is no longer needed? Remember, in order to know whether you have PCR or not, you have to do surgery, right? Because you have to have that tissue excised to examine histologically. But are there non-invasive means using imaging to predict PCR so that we don't need to do that excision? So that's the question we're going to keep in our mind as the lecture continues. And this is important because there's definitely increasing use of neoadjuvant therapy. This is data from the United States National Cancer Database, ranging the 5-year period from 2010 to 2015. During this time period of chemotherapy patients, majority, 80%, still given in the adjuvant as opposed to the neoadjuvant setting. but the trend is definitely increasing in the administration of neoadjuvant therapy, particularly for certain subtypes. Triple negative use increased from 19.5 to 33.7%. The HER2 positive, 21.5 to 39.8%, and the triple positive from 17 to 33.7%. In contrast, your relatively good prognosis cancers, that is your hormone receptor positive, HER2 negative luminal cancers, yes, the use of neoadjuvant therapy also increased in this group, but the extent of increase, the magnitude of increase is much less, from 13 to 16.8%. So you're really looking at the use of neoadjuvant for these patients, triple negative, HER2 positive, and also triple positive. Let's look at such a case. This is a palpable lump, a very classic appearing triple negative grade 3 invasive ductal carcinoma. Mammogram shows a dense mass, relatively round. Some of the margins are circumscribed, some margins are indistinct. And here the ultrasound images show a hypoechoic solid mass, very classic for triple negative invasive ductal carcinoma. And this cancer showed response to neoadjuvant therapy. Pre-treatment, there is the mass. At 4 months, you have the mass really no longer seen, but a vague asymmetry associated with this, which is the biopsy clip. And then at 7 months, hardly anything left. And of course, it's important to have that biopsy clip so you know where the abnormality was, where the tumor was for purposes of surgical excision. This is the correlating ultrasound images showing you the mass, largely resolved with a little bit of a residual hypoechogenic region here, and associated with this, which is the echogenic focus, that is the biopsy clip. And then at 7 months, really not much of anything left. There is a flattened area of hypoechogenicity, which represents the residual tumor bed. And again, you know this is the region because of the echogenic focus. That is the biopsy marker clip. Imaging assessment can be challenging. I showed you a nice mass that resolved completely, but oftentimes the information may be imprecise, not quantifiable, and the response by imaging may be subtype dependent, whether they're luminal cancers or triple negatives, for example. So histology remains the gold standard for determination of response. But even with histology, partial response can be really challenging to classify. And mostly because there are various response patterns. The big categories are concentric, where you have a big mass becoming smaller, versus scattered, where you have scattered tumor cells within reactive stromal background. And that may be difficult in pathology to detect and to quantify. Let's look at the nodes now for a bit. Nodal disease is common in patients who get neoadjuvant therapy because these are patients that tend to have locally advanced disease or inflammatory breast cancers. And these are conditions which is very often associated with significant adenopathy. Now, neoadjuvant therapy is more effective for cancer in the breast, parenchyma, the breast tissue, than in the nodes. For example, patients who have demonstrated PCR in the breast tissue, of those patients, 16 to 41% will still have persistent nodal disease. Given I said that, of course, neoadjuvant therapy can also help with nodal disease, and you want that because nodal response has been correlated with longer disease-free time and longer survival time for the patient. Another case, these are axial MR images, before neoadjuvant therapy on top and after neoadjuvant therapy on the bottom. What I'm trying to show you here is a rim-enhancing mass that represents an invasive ductal carcinoma shown here in the posterior lateral aspect of this breast. This signal void is a biopsy clip. After neoadjuvant therapy, nearly completely resolved. And this is that same cancer before treatment and after treatment in the sagittal plane. Again, you see the mass, inferior posterior, and this mass has resolved, showing you only the biopsy clip left. And this is that same patient. She had that unifocal cancer, and associated with that ipsilateral, she had axillary lymph node involvement, metastases to the axillary nodes, because this is what we're seeing before neoadjuvant therapy. And afterwards, you see that you can have response to the nodes. These are the sagittal images, and these are the corresponding, these are the axial images, and these are the corresponding sagittal images shown here before and after neoadjuvant therapy, a good response. In the first lecture, I talked quite a bit about the use of ultrasound in nodal staging, and I'm now going to show you various images of ultrasound in assessing nodal response. Here we have axillary level 1 lymph node that is involved with cancer. You remember the 6 types of lymph nodes, and I would say this is a type 6 node with complete replacement of the fatty hilum. Before chemotherapy in the transverse and longitudinal planes, and after neoadjuvant therapy. And you can see that you have a decrease in size afterwards. I'm going to point this out to you, which is a biopsy clip, the echogenic focus, and there it is after the administration of neoadjuvant therapy image. And you can see that it can be subtle, but you want to identify that because this represents to us the clipped node. The clipped node in this subset of patient is defined as the node that was diagnosed with cancer at the time of staging, and a biopsy clip has been placed to denote it. And I'm going to talk about the significance of this as we talk about the targeted axillary dissection later on. But let me show you other examples of nodes. And here is one that is a Rodder's node. Remember, Rodder's node is an axillary level 2 node and a node that is located between the pectoralis major and pectoralis minor muscle. So this is a good example, again, of a type 6 lymph node with the fatty hilum completely replaced and showing you in the transverse and longitudinal plane. After neoadjuvant therapy, you see that there is nice response. The node is much, much smaller, shown here in the transverse and in the longitudinal view on ultrasound. And then another example, another regional nodal basin in the transverse and longitudinal planes. On the top is pre-neoadjuvant therapy. On the bottom is afterwards. I'm labeled the ribs for you. So I'm showing you a structure that is between the ribs. Again, this is a lymph node, shown here in the asterisk, again, type 6 with complete replacement of the fatty hilum. Before neoadjuvant therapy, quite large. After neoadjuvant therapy, flattened out, has improved. So again, a good response. Internal mammary node between the ribs. Okay, so surgical excision of lymph nodes. We do this as treatment to reduce the elimination of tumor burden in the nodes, and we also do this to prognosticate, because the stage is highly correlative with survival. And oftentimes we perform this in order to get accurate information about lymph node status in the axilla. That is surgical staging. Now, there are different ways to excise nodes, and the 2 most common ways is the sentinel lymph node biopsy, which is just a few nodes for the smaller cancers, earlier stage disease. And then you have your axillary lymph node dissection, which are many more nodes, okay? So I think that we're likely familiar with these 2 techniques, most of us. Now, there is a little bit of a newer technique, which is somewhere in the middle between a sentinel lymph node biopsy and an axillary lymph node dissection, and that's called a targeted axillary dissection. That's basically the surgeon excising the sentinel lymph nodes plus that clipped node I showed earlier. And that is increasingly performed in the setting of patients who get neoadjuvant chemotherapy. And indeed, in our institution, we wrote a review article in 2016 on our methodology, radiologic mapping for targeted axillary dissection from the needle biopsy to excision is the title. And let me show you a case from our practice. So here is a mammogram showing you a large cancer. And this is the large mass that is associated with the biopsy clip. There it is. That's a triple negative cancer, a hypoechoic solid mass. This echogenic focus is the biopsy clip. And just to show you for the complete story, this is the CT showing you this locally advanced large breast cancer involving the right breast. Now, this is a triple negative breast cancer, and it is responsive to neoadjuvant therapy. Again, reminding us this large mass before chemo And after chemo, with near complete resolution, only the biopsy clip remaining. Okay, so this is a very, very good response inside the breast. But let's also look at the lymph nodes. This same patient, this is what her lymph nodes look like. Before chemo, you have the abnormal node, and this is the clip node that has been marked by this U-shaped marker. I'm going to show that to you larger and more clearer here in this photographic enlargement. This is adenopathy in the axilla, and this is the marker that we use, the clip. And here, after the administration of neoadjuvant chemo on the right-hand side, you see that the node has responded. You no longer see this as a large structure as well. And in addition, you have this, which is a magnetic seed we placed to mark this node preoperatively. So then the surgeon can use it to find this clipped node for the purpose of targeted axillary dissection. And this is the surgical excisional tissue radiograph. So what I'm showing you here, these are surgical clips. What we're looking at here is the lymph node, the clipped node that was excised as part of the targeted axillary dissection. The U-shaped clip marks the metastatic node, whereas this straight bar here is the localizing seed we placed under ultrasound preoperatively, which is a magnetic seed in this case. So this is part of our targeted axillary dissection process. I'm not showing you any sentinel nodes here. What I'm showing you here is the removal of the clipped node and how we use X-rays to document the removal. Okay, so for the last half of my lecture, I'm going to talk about the different imaging modalities. And when comparing clinical breast imaging, mammography, ultrasound, MR, and MBI, molecular breast imaging, of these various modalities, the highest accuracy in terms of assessing residual tumor is MR. Okay, that's the modality that has been shown to be most accurate, but in various literature. Nevertheless, of course, mammography and ultrasound have a role. You know, they're accessible. They are something that's commonly done, and they give us an overall picture often of what's happening. Here on the left, MLO mammogram before administration of neoadjuvant therapy, and on the right afterwards. You see that this is a case of inflammatory breast cancer, dramatic skin thickening. There is diffuse global asymmetry, trabecular thickening, and of course, axillary adenopathy here. But after neoadjuvant therapy in the post image on the right-hand side, you see that there is improvement in the skin thickening, as well as improvement in axillary adenopathy. Now, there is still a palpable lump as shown here, but of course that lump can represent fibrosis and scarring after the response to therapy and not only tumor. And overall within the mass, that global asymmetry has improved. Here's an example of improvement or response to neoadjuvant therapy at ultrasound. This is a large irregular mass, hypoechoic with angular margins. I'm showing you in the transverse and longitudinal planes. At biopsy, this was an invasive ductal carcinoma. After 1 month of neoadjuvant therapy, it's gotten smaller. The shape is still relatively retained. This is the clip here, the echogenic focus that I'm pointing to. But by the 2 months here, you see that there's more response. You no longer really have a mass. You have more of starting to have more of a tumor bed. And by 3 months, you have definitely more of the tumor bed situation where you just have hypoechogenic material, kind of flat. Here is the echogenic clip, the marker. There it is. And again, comparing the pre-neoadjuvant chemo, how it started out, and afterwards, you have that is your marker. You see the biopsy clip as an echogenic focus and hypoechoic residual tumor bed. Okay, let's go talk about MR. And MR is special in many ways because of the angiogenic response prior to reduction in tumor size that we see. That is, changes in tumor vasculature and metabolism may be more sensitive than the traditional structural measurements that we have. So let's take a look. Before chemo on top, after chemo on the bottom. This is a case of an inflammatory breast cancer. And what you have here is a diffuse non-mass enhancement of MR, as well as skin thickening. And there it is. And you also have adenopathy. So the skin thickening the diffuse non-mass enhancement and the adenopathy pretty much all resolved. So this is what MR can show you as a good response. Now, this is another case. This is meant to be an invasive ductal carcinoma enhancing mass. And on the top row here, you see this mass, the color parametric map, showing you red, which represents washout kinetics. But here's the mass at the maximum intensity projection image. You do not see that anymore after administration of neoadjuvant therapy. And then you have here the lobular carcinoma, which is presenting as a segmental non-mass enhancement before therapy, 3 months after therapy, and 5 months after therapy. You see that within the breast parenchyma, nearly complete resolution. In the adenopathy itself, it remains. And we know that because remember we talked about the fact that neoadjuvant therapy is more effective in the breast than the lymph nodes per se. So very classic response, invasive lobular carcinoma, non-mass enhancement. MR is more accurate than other modalities for invasive lobular carcinoma, which is always a tricky entity for us breast imaging radiologists. But even though I say MR is the best tool, it is still tricky. It is particularly tricky when the lobular carcinoma presents as diffuse non-mass enhancement as opposed to enhancing mass. MRI is less accurate for the luminal subtype tumors and more accurate for triple negative and HER2 positive cancers. It is least good for ER positive and low nuclear grade. And this is very interesting that one response is subtype dependent, and two is the fact that it is more accurate for the triple negative and HER2 positive, which is good because these are cancers that tend to be biologically aggressive and therefore clinically significant. Let me tell you about a long-term study called ACRIN 6657. ACRIN stands for American College of Radiology Imaging Network, and this one is numbered 6657. The title is Contrast Enhanced Breast MRI for Evaluation of Patients Undergoing Neoadjuvant Treatment for Locally Advanced Breast Cancer. This study has 377 patients, and basically MR measurements are obtained between different groups, and we're assessing tumor response and determining if there are statistically significant differences in 3-year disease-free survival as endpoints. So to this end, one of the major papers that came out of the long-term study is this, published in April 2016, consisting of 162 patients with cancer that are greater than 3 centimeters or greater. And the conclusion was that the functional tumor volume was a strong predictor of recurrence-free survival, and that's great. So as radiologists, rather than saying that bigger or smaller a resolve, we actually can tell the patient, looking into the future, what will happen. Functional tumor volume 2, that is the tumor volume that is measured after the first cycle of neoadjuvant therapy, turn out to be the strongest predictor. So that's an early predictor. And MRI was found in the study to be most useful in prognostication for the triple negative and the HER2 positive disease, subtypes that are most likely to cause death. To be exact, the positive predictive value for PCR in these triple negative HER2 positive cancers were nearly 74%, versus the positive predictive value for PCR in the luminal subtypes were only 27%. Now, I don't want you to think that MR is not good at all for the luminal types, so I want to share this article with you from January 2018 from Japan, which found that in the luminal, low-grade luminal breast cancers, the concentric response, remember you have concentric versus scattered, and if the response is concentric pattern, that turned out to be a significant independent predictor of longer overall survival and longer disease-free survival. Okay, so that was interesting. And as a note at MD Anderson, what we're currently working on is imaging assessment of neoadjuvant therapy using some other parameters. For example, the levels of tumor infiltrating lymphocytes, and for example, tumor necrosis radiomics, just to share with you some of the ongoing research. Going back to our question, can RCR be used to predict PCR so that surgical excision is no longer needed? Well, at this time, not so much because of false negatives at imaging due to decreased cellularity or vascularity. so that surgical excision is indicated, even if there is complete response at imaging, even if you have RCR. That is still the standard of care. But I asked the question again, with advances in technology, can RCR be used to predict PCR so we no longer need to do surgery? Well, it turns out that perhaps, maybe, if core biopsy is performed in addition to imaging after the completion of neoadjuvant treatment to exclude residual disease. And this is what we're calling trials in eliminating surgery for neoadjuvant therapy patients with great response. And it turned out that patient selection is a very important part of this process. And just to share with you one article from our center, primarily from the surgeons, in October 2019, that talked about selection for HER2-positive breast cancers treated with neoadjuvant systemic therapy. But going back a little bit in terms of the biopsy part and what we radiologists do, this is from 2018, and this is a biopsy feasibility trial. What we did was that we are looking at our patients who respond well, and they're called the exceptional responders. And if they're exceptional responders, the question is asked whether we can have no surgery in these patients and follow them only, observe them only, which would be a big change in the way that neoadjuvant therapy and subsequent surgery is being performed, changing the standard of care. Another term for this type of work is called the de-escalation trial. De-escalation means you're doing less, and in this case, no surgery is the less part. So this is from the 2018 biopsy feasibility study. Okay? And what our institution primarily rely on is mammogram and ultrasound, but we found that imaging alone doesn't achieve great accuracy. But when you add core biopsy or FNA biopsy and vacuum-assisted core biopsy is when you have highest accuracy. So what we do now is if a patient responds really well at imaging, then we do a biopsy and the biopsy is negative, then the patient may be randomized in a trial that is observation only without surgery. And let me show you such a case. This is a patient with a cancer that is a mass here in the posterior aspect on this MLO mammogram. This is the biopsy clip. And here is the ultrasound showing you that cancer before administration of neoadjuvant therapy. This is afterwards. Good response. I don't really see the mass anymore. This is the biopsy clip. And ultrasound also, hardly any finding. What happens with this patient is that we would take her to stereotactic biopsy and we would use that clip as a target. And we would obtain at least 12 core samples using vacuum-assisted 9-gauge, which is our protocol. So after we make sure that we remove that clip, because that clip marked the site of previous cancer, the pathologists then analyze these tissues. And if there's no residual tumor left, then the patient is eligible for observation for only in our exceptional responder trials. So that's what we do. There was the clip. Just to show you the mammograms again, this is the clip that was marking the initial cancer, and the mass largely resolved after neoadjuvant therapy. And remember, we then went ahead and did stereotactic biopsy, removing this clip, making sure that this region doesn't have residual disease. And we placed a different shape clip after that stereotactic biopsy. To show you the image is bigger, here it is, the first clip removed with the 9-gauge vacuum, 12 sample stereotactic biopsy. We want to make sure those tissues have no disease. And if there's no tissue left, then the patient may qualify for randomization in the exceptional responder trial, okay? And we put in a new clip of a different shape. And there is the new clip of a different shape now. So in conclusion, this is done not only now at our center, but really around the world. This is a multi-institutional and international collaboration trial. It was published in JAMA Surgery in October 2020, so very recent, involving MD Anderson in Houston, the Royal Marsden in London, as well as the Seoul National University in Seoul, Korea. And the conclusion of this study, which included 166 women, was that when you add biopsy, and in this study, it was done with 6 or more samples. At our institutions, we do 12 or more, but altogether, false negative rates less than 5% in predicting PCR. So the conclusion is that we're moving toward using RCR coupled with biopsy to predict PCR. In summary, neoadjuvant therapy has an increasing role in clinical practice, increasingly administered, particularly for certain subtypes that are biologically aggressive. Imaging has important role in assessing response, MR being the most accurate, but ultrasound and mammography also have their role. Management of nodal disease is evolving. Increasingly in neoadjuvant setting, the TAD, targeted axillary dissection in patients who respond well, is being performed. And the entire neoadjuvant therapy management paradigm is evolving so that there is movement toward de-escalation of treatment. And in this particular setting, we're talking about substituting observation for surgery in patients who show exceptional response to neoadjuvant therapy. Thank you very much to the organizers of this meeting, of BGICC organizers, for the privilege to be able to partake in this conference. And thank you to the audience for your time, for your attention, and for your care of breast cancer patients in your clinic every day.